I'd like to ask Nicholas Smith from Australia to help us work out how to arthroscopically reduce complex fractures and make it easier. Thank you.
Thanks, Jeff. So we're all familiar with this, and I'm probably not having to convince anybody here of the benefits. Just some thanks to the pioneer, Dr. Abe. Thanks to Mark Ross for taking that photo for me. And also to Paco Del Piñal, who I think has taught us all a lot about this problem and how to best treat it. Some of his key lessons that I have found very useful. One is dry arthroscopy. I think this is very important. The most important thing is you don't get swelling, and it takes the pressure off you in terms of the time, so you can relax a little bit. The important message is to get an accurate articular reduction as well as extra-articular parameters, and to minimize, as we just saw, the articular steps and gaps which can lead to fibrous bands leading to decreased wrist motion without really adding any morbidity, especially if you're using dry arthroscopy. Here's something from Paco's atlas, and it demonstrates, firstly on the left, the reduction of the palmar fragments onto the plate and then holding them with K-wires through K-wire holes, subsequently reducing the dorsal fragments under arthroscopic control, and then finally definitive fixation. The problem can arise when the K-wires toggle or wobble in the holes. Secondarily, adding the definitive fixation whilst in traction is really a two-surgeon procedure. It's quite complicated, difficult. You're never quite sure what's happening with the drill, whether there's a nerve or a tendon being wrapped around the drill while everybody's looking at the video monitor. So it's probably only for very experienced expert surgeons. The purpose of this system is to try and make it more easy, really. This is an illustration of the system. You can see there's K-wire guides which hold the K-wires to the plate, and the rest of the system is cannulated to make sure we don't lose reduction after we've achieved it. So the concepts are increased stability between the temporary K-wires and the plate, and easier fixation during arthroscopy, also not to lose the reduction once we've achieved it arthroscopically and we're changing to definite fixation. The components of the system are a special plate, K-wire guides which insert into the locking holes, and of course the K-wires. A new plate was designed with this in mind. Mark Ross introduced the idea of having two styloid screws to help with stability, but also during the procedure. Subchondral support of the screws and non-convergent screw vectors so that the guides don't butt on each other. So here's the plate with the guides, K-wire, and the instrument for removing the guides and measuring the screw or the peg length. So the steps are, firstly, achieving reduction of the volar fragments under direct vision, interdigitating the fragments. Then we apply the plate, we localize it very carefully, then fix it proximally with the screws. We can then insert K-wires into the volar fragments, and you can see we only introduce the K-wires maybe a centimetre, only fixing the volar fragments. This is very important. We wish to leave the central fragments and the dorsal fragments still mobile so that we can reduce them arthroscopically. We go into traction. I use vertical traction, and you can see the K-wires protruding, and they're easily accessed. The guides help protect the soft tissues so that when you spin the K-wires, you don't wrap tendons or nerves around the wires. We go to the arthroscopy. We look at the articular surface, reduce it via whatever method is necessary. Here it's just thumb traction, but the point is that you can be concentrating on the screen. The surgeon is looking at the screen, controlling the reduction, and not having to worry about what's going on with the K-wires while the assistant advances the wires and secures a reduction. Then it's a matter of taking the arm out of traction, measuring the screw length from the K-wire, removing the guide, over-drilling the wire with a cannulated drill, and then inserting the cannulated pegs. And so there's much less risk of losing your reduction whilst going from the provisional to the definite fixation. The system does work on any of the 2.4 millimetre plates, and here's a very distal fracture where we needed to use a volar rim plate. The same guides and wires can be used, and we were able to achieve a very satisfactory reduction. So it's a technique presentation. There's no statistics. I hope you find the technique helpful if you're into that sort of thing. Thank you very much.
Thank you, Nick. Are there any questions from the floor? I have one on my left, far away.
I have a question for you, Nick.
Philippe.
So, it's not the question that you asked me to ask. Yes, your technique is very clever. You try to make it simple, but you still use a large incision and you don't respect the pronator. So do you think you can use this technique with a minimally invasive incision?
Well, I just used the larger approach so you could see what I was doing for the purposes of the presentation, Philippe.
Nicholas, I have just one question to you.
Thank you.
Sometimes I feel that it's very difficult to restore the volar tilt of the volar lunate facet for the first fixation. Do you have any tips?
What I do is I interdigitate the fragments, meaning line them up very carefully, and then apply the plate. And then once the plate's securely fixed with screws, then I push with manual pressure everything onto the plate, and thereby pushing the volar fragments onto the plate, and then it's easy to put the KYs in and fix it onto the plate in that reduced position.
Nick, what do you do with the severely comminuted one that's, Humpty Dumpty? It's a little bit difficult. Do you just hang it up in traction, then arthroscopically reduce it, convert it into a two-part, and then reduce it? How do you tackle the really ugly one?
Again, the same way. When I used to use plates everywhere, volar and dorsal plates, I used to start on the volar side because the volar side is where there's usually less comminution and you can usually start getting somewhere. So getting fragments lined up, and then, so I would do the same technique. And you build stability as you achieve reduction and then achieve some stability in what you have, then it's easier to put the puzzle back together.
Well, thank you,
And
Nick.
I think it's still possible arthroscopically, even in those exploded fractures.
Me too. Yes, question?
Do you have any experience from a delayed fixation of these fractures, like 2 weeks plus? Do you have to use bone graft for die punch fractures when you reduce them, when there is a big cavity underneath?
Yes, I have, and taking it out to the ultimate degree, even if you're doing an intra-articular osteotomy, I think it's still possible to use this. I mean, it's the same technique, but you just add the osteotomy. And usually mobilizing the fragments, you can just do that with a Freya dissector or a dental hook or something. I don't use bone graft, even if there's quite a large defect. I think the plate's enough now, the fixation's adequate. I definitely don't like bone graft substitutes.
Thank you.
Thank you.
Nicholas. Now we move on to the next paper. The title is